In this video, I answer a question from a 42-year-old female who was diagnosed with a torn labrum, also known as cartilage, in the shoulder and is trying to decide if surgery is going to be the best option. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a chronic pain treatment expert with over 15 years of experience, specifically for neck, shoulder, elbow, and wrist pain. My focus is on finding and fixing nerves that get stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain naturally without the use of medications or injections. This leads to a big increase in overall functioning, flexibility, and long-lasting pain relief. Just a quick disclaimer on why I make these videos. I make these videos not to entertain, but specifically for anyone who has been dealing with chronic neck, shoulder, elbow, or wrist pain for at least 6 months. They've tried just about every type of treatment. They've been lied to, overpromised, and underdelivered by the current medical model, really in hopes of trying to give some real answers as to what is going on and get to the root cause of the problem to get some long-lasting pain relief, finally. Now on to the video. All right, so what am I going to cover in this video? First, I'm going to cover why does the labrum get torn even without a direct injury? Next, how can you ensure that the correct imaging was done to diagnose the issue properly? And how to avoid the surgery and get the injury resolved naturally. So let me just go over the history and the symptoms and just the story of the question that came in. It was from a 42-year-old female. She is very active and been having shoulder pain for the past 2 years. They noted that it had progressively gotten worse after a hard CrossFit workout where they heard a pop, and now the shoulder clicks all the time. Noted that it's painful with certain types of motions, more like everyday motions. She had noted like reaching for something in the cupboard, putting their seatbelt on, trying to like unhook a bra or get dressed. Definitely worse with sleeping or lying on it as well. She noted that there wasn't any history of like direct trauma, no accidents, car accidents, falls, sports injuries like that. Kind of just came out of nowhere besides that one day where she felt the pop and the click after a heavy overhead workout. Got an MRI done, and it came back with a partial tear of the labrum, also known as the cartilage, and it was diagnosed as what's called a slap tear. Slap tear is just it's a way of describing where the labrum and the cartilage tore and where it went in that order. It's probably the most common labrum injury that I see in shoulders as well in my practice. They also did 3 rounds of injections of cortisone. She noted that it did help with some of the pain, but as soon as they got back to the activity, it just really came right back again. And the injections really didn't feel good when they got them done as well. And also did 6 weeks of physical therapy that really worked on trying to build up the strength in and around the rotator cuff muscle. And they also did a lot of core stability as well. And she noted that the exercises really just made it feel worse and didn't do much of anything, but did the full 6 weeks of physical therapy in order to cross the barrier to get the MRI approved by insurance. And after all this, surgery was recommended by 2 separate surgeons in this issue, and both wanted to do a very similar approach of repairing and anchoring the labrum. So let's get into this. So this image I have here is pretty cool. It is a look at the inside of the shoulder and where the labrum is. Now, a big question that I'm always looking at when I have an injury in my practice is, was there a direct trauma to the area or not? A lot of times when there isn't a direct trauma, I'm usually thinking that it's the injury to the labrum itself or the cartilage or the joint is coming from it getting overloaded. And a lot of times it's more of the effect than the direct cause. And next was, did they even get the right imaging? So a standard MRI doesn't show us everything. If I'm really looking at the cartilage in the joint, I want to get what's called an arthrogram, an MR arthrogram, where they actually inject into the joint as well, because I want to know for sure where those tears are, if anything else is compromised as well. So a lot of times they make calls off an MRI, but they don't have the best imaging that they could actually get. Next is just age is a big factor here. You know, she's 42. And cartilage damage in surgery just doesn't do well long term. The cartilage just doesn't get a lot of blood flow, doesn't get a lot of oxygen. It takes a long time for it to heal up. And a lot of times I've seen people get these surgeries and it'd be a lot worse, especially if you're over like the age of like 25 or 30. Your body just doesn't heal like it should. So in this situation, for what I'm seeing in the history with no direct trauma, we should actually start by fixing this problem conservatively. And in the rest of the video, I'm going to go exactly how our providers trained in the PEAK method would go through treating this. So the first thing that I see when there's not a lot of direct trauma in the shoulder is the nerve that controls a lot of the rotator cuff. It actually gets stuck. So nerves are built with about 15% of like extra slack to make it through the body and go where it needs to go. Over time, with repetitive overuse, bad posture, stress, everything like that, living in modern society, sitting all day long, staring down at our phones, the muscles get overworked. They don't get enough blood flow. They don't get enough oxygen. They start to lay down this stuff called adhesion. It's also known as scar tissue. And basically it gets inside the muscle, makes it less flexible and weaker. But eventually it gets stuck to the nerve and creates an entrapment. So where the suprascapular nerve really likes to get caught is in this big muscle of the back part of your shoulder blade called the infraspinatus. It's very important in shoulder motion, movement, and it actually comes out right below here in what's called the suprascapular notch. And that's the most common area where I find an entrapment of the suprascapular nerve. And the suprascapular nerve actually controls two muscles in the rotator cuff. It controls the supraspinatus and also the infraspinatus. So when the nerve gets compromised, it can cause a lot of issues. And it causes the motor function or just the movement of it to be altered. So now the muscles can't do what they're supposed to do because the nerve is getting jammed up or getting stuck. So the force has to go somewhere. So whenever I'm looking at an injury, the most important thing I need to address first is actually the nerve entrapment. If the nervous system doesn't work correctly, nothing else works correctly, then you got a whole series of like compensations and biomechanics are all over the place. So we first need to go in there and actually address and treat the nerve entrapment first before we do anything else in the rest of the shoulder. And when we're treating the nerve entrapment, it's very specific where we go. It gets caught in a very small area and it needs a very precise and focused type of treatment. A lot of times when most providers find this, they end up treating it too aggressively. They might go in there with their elbow. They might really beat the tissue up, and the nerves don't like that. They want just the right amount of precision and depth. And basically what we do is we get in there, get some depth and tension on it, break it down, have the client go through a full range of motion, and that slowly frees up that nerve. If you just go in there and jam on it, you're really just going to make it angry, and it's not going to do much of anything, and that entrapment is still going to be there. Next muscle that we would address after cleaning up the suprascapular nerve would actually be the subscapularis muscle. It's actually in the front part of the armpit, and it's the only muscle in the rotator cuff that stabilizes the shoulder from the front. So in a lot of chronic overuse injuries in shoulders, this muscle just really gets beat to hell, develops a ton of that adhesion, a lot of scar tissue throughout there, and now the shoulder can't be supported from the front, so it ends up kind of dumping forward, which puts more pressure on the cartilage in the joint itself. And a lot of times when people are getting this area treated or addressed, by a manual therapist, maybe a massage therapist or a PT that does some type of soft tissue work or a chiropractor, is they're way too compressive with it. This muscle is very thin. It sits right on the front part of the armpit. And a lot of times when providers are treating it, they're too aggressive, they're too compressive, and it just really hurts like hell and it's not doing much of anything. But this is a really key muscle and you got to go slow and precise and focused, just like I talked about with that nerve entrapment. Once we clean up that, then we're going to start looking into what's called the shoulder capsule. And it's basically like a ball of ligaments that surrounds it allows the upper bone called the humerus to attach to the shoulder bone called the scapula. And it's really important in shoulder movement and stability. So basically, whenever you're moving your shoulder, you're reaching, you're lifting overhead, you're doing stuff, the capsule has to kind of pull tight to keep some stability, keep it from getting too loose and moving around too much. And it's so important in shoulder motion and function. And a lot of times what happens is it develops a lot of that adhesion too, because when the joint, or not the joint, when the nerves are caught, the subscap isn't functioning correctly, the force has to go somewhere. And a lot of times it ends up going to the capsule. And the capsule isn't designed to do as much work as it does. So it develops a lot of that adhesion as well, and it becomes less flexible and weak. Now, getting in there and treating it is actually very important because a lot of providers, when they're trying to find the capsule, they actually miss it. They're usually too far back on the deltoid or too far on the tricep as well. And they think they're treating it, but they're not. Slowing down and finding it and getting the right amount of depth and tension on it is key. And that's where that precision in what our providers do, getting in there very precise and very focused, going in there and breaking down that adhesion as well, which will restore some range of motion back to the shoulder and get it functioning better. And like I said, that proper treatment of it, it's got to be just the right amount of depth, just the right amount of pressure. If you're too compressive on it, you don't get the right change. If you're not compressive enough, it doesn't change as well. It's very precise, very focused. It's not just some shotgun type of approach. So how do our providers address the problem to get long-lasting relief? First, we just start with knowing all the components of the injury and the pain presentation. We do a very detailed consultation, a very detailed functional evaluation, so we get all of the data. Instead of just jumping into a treatment and be like, oh, your labrum's torn, let's treat it there. I want to answer the question, and my providers want to answer the question of why did this happen in the first place, especially if there wasn't a direct trauma. Then we start, as I said, by addressing and treating the nerve entrapments first. We have to free those up first because if we treat the other stuff before we treat the nerve entrapments, everything's going to come back because the body's trying to protect that nervous system. Then we go in and treat the adhesion in the muscle, specifically in the subscap, as I talked about. Then we go in and treat the adhesion in the capsule. We have to stay in that order because a lot of times if we jump around, it's not going to allow lasting changes and not allow that function to continue to improve. And also throughout the process, we also help by reducing inflammation through diet and lifestyle, really helping people get some of that inflammation down. A lot of times people are just eating lousy, they're inflamed, and that inflammation doesn't help as well. So we want to make sure we attack that aspect of it as well. And then once we get all the range of motion back by freeing up the nerve entrapment, by getting rid of all the adhesion in the armpit muscle and then clearing up the capsule, we need to start to build it back up with some corrective exercises that really isolate different muscles of the rotator cuff. Now, physical therapy isn't the wrong treatment, but a lot of times people start with that before they actually clean the muscles up. So this is why in this situation for this person, they were actually getting more pain because the tissue wasn't healthy yet. We got to get the tissue healthy first, then we can balance the strength. Once we balance the strength, then we want to increase the overall strength. So we really do a lot more work globally in the shoulder. We look at the whole shoulder itself. We do more aggressive type of strength training. We do a lot of buildup in the mid back as well, in the thoracic spine, to really make sure that that area stays strong and functions a heck of a lot better. Now, in this situation, the worst case scenario, we'd go in, we'd clean up all the tissue, we'd reduce the inflammation, and we'd restore the range of motion. And if the client is still having pain from that cartilage, then they can go have the surgery and it'll actually be a lot more successful. But what happens is so many people jump to the surgery right away. I always say, think of the cartilage damage as like your thumb and it's stuck inside a car door. The car door is actually all of that adhesion and those nerve entrapments. We can't give this a chance to heal up until we remove that. So we start with this naturally and conservatively by getting everything functioning better. And a lot of times people don't end up needing the surgery anyway. And a lot of times the cartilage and the damage and the degeneration isn't the big pain generator, it's the other things. And the best part about all this is it's very safe. There's not a lot of risk involved with it. Surgery can have a lot of risk. You can get an infection, could have a reaction to the anesthesia. You could have a lot of different problems and it might not even work. So I always say, start here, start conservatively. And if it doesn't get better, at least on the rehab side, on the back end, it's going to go a heck of a lot better as well. So that's all I got in the video. If you want to get some help from a provider and does what we do, the best providers in the world for treating chronic shoulder pain naturally are trained in my system called the Peak Injury Treatment Method. And when you've had enough of constant shoulder pain and discomfort, reach out directly to us and request a no-charge injury consultation to get some real answers as to what is going on and on the path to long-lasting pain relief. Links to request a consultation are included in our profile or wherever you're watching this video. I appreciate you watching, and we'll catch you on the next one. Bye.